know me, I spent a lot of time in my career building workflows because I think sometimes we have science that's ahead of technology and technology ahead of science. The most important thing in the cath lab to be successful is to build a workflow. That's what we did with MLD Max. That's what we did with Cath CMD. And now we're working on this ACT PCI algorithm because we know that algorithmic care improves clinical outcomes. So first of all, the question is, why should we use physiology for PCI guidance? And I think we learned some very important lessons from this important study from my colleague Alan Jeremias. Because this is a 467 patient study where there's angiographically successful PCI and there's an IFR pullback performed at the end of the procedure that's blinded to the operator. And so what did they learn? They learned that in almost a quarter of patients, the IFR remains in the ischemic range, even though the angiogram looks normal. And as you know, this number is very similar to the number for post-procedure chest pain or persistent angina that occurs. So the hypothesis is it simply if we do angiographic PCI, we're ending up with a lot of residual ischemia that is causing the residual angina that continues to be a problem in interventional cardiology? Well, then a very important question comes up, and that it says, well, fine, if I have 24% post-PCI residual ischemia, it must all be diffuse because I couldn't see it on the angiogram. But when we studied this, actually we found that 82% of the missed ischemia is actually focal disease, something that was missed by the angiogram that's simple and straightforward to teach. Here's an example of a patient with what looks like a very simple, straightforward focal lesion in the distal LAD. And while there's some moderate disease proximally, you can see the final angiogram after treatment of this distal vessel shows what angiographically looks like a reasonable result. And in the pre-PCI IFR spot, you can see that the lesion's very ischemic, not surprisingly given this very tight lesion. But actually, in the post-PCI IFR, what you noticed is that you have a residual, very severe step up in the proximal vessel. And so actually, most of the ischemia is not coming necessarily from the distal, but also including in the prox. So the point is going away from the concept of a spot measurement and determining whether ischemia is present or not, rather using the physiology as a roadmap similar to intravascular imaging. And if you do that, what we found in defined PCI was that if you get to a residual ischemia level of an IFR of greater than 0.95, your event rate is very, very low. Whereas if you're lower than 0.95, your event rate is in the 6% range. Now, it's really important for us to understand the difference between diffuse and focal disease, because diffuse and focal disease have a different pattern. That different pattern also has potentially important different applications for the patient. And this very seminal study from my good friend Carlos actually showed very clearly that if you have focal disease, it correlates much better to patients becoming angina-free, comparing if you have diffuse CAD, where the ability to improve the patient's symptoms is much, much more difficult. Hence, determining focal from diffuse is critically important and able to create a residual improvement in function. Now, let's look at some examples of IFR pullback and angiography co-registration for planning. Here what you can see is a very ischemic vessel with most of the pressure loss happening in just past the distal left main in the proximal LAD. Now, you can actually use the planner to do various different lengths of stenting. If you do 28 millimeters here, you'll cover the gradient. If you do 24 millimeters distally, you'll miss the gradient. And if you put a longer lesion and cover all of this, you'll actually need up to 60 millimeters to cover the entire lesion and get back to a point of greater than 0.86. And this is the reason we created this new algorithm called the ACT PCI workflow. And we'll go through these step by step. But essentially, ACT, the A is for assess, C is for co-registration, T is for treat, and following PCI for post-treatment optimization, P is for pullback, C is for co-registration, and I is for improve and fix the problem. Let's go through this. So first of all, in the assessment, what we'll be doing is doing an IFR spot measure in the distal coronary artery. The answer to this is the lesion ischemic or not? Consider the spot FFR if you think it's indicated. The IFR pullback with co-registration is then performed, and then we obtain a cine angiogram to co-register, because this is the only way to truly map what's on this pattern onto this angiogram. Because we don't treat curves and lines, we treat angiograms. And so what you can see when you co-register is that you can establish disease patterns such as single, focal, diffuse, or diffuse and focal. You can create a treatment plan based on the virtual stent tool, which you can see placed right here, that 10 millimeters will create a delta of 0.09 and get us back up to an IFR estimate of 0.96, as a result getting us above the 0.9 threshold. We can consider targeting a post-PCI goal of 0.95, and importantly, in the setting of diffuse disease or other complexities, a lower post-PCI IFR goal may be acceptable, just simply getting out of the ischemic range. One of the very important things about the Philips system in particular that no other IVUS system has currently, no other IVUS allows you to co-register, certainly no other IVUS system allows you to tri-register, where you have the option of co-registering IVUS with physiology onto your angiogram. So really this is the trifecta, right? Because you're able to not only determine whether there's ischemia, determine where the majority of the ischemia is, but then also map the MLD max going from normal to normal and covering this lesion in entirety. And tomorrow we're going to have some sessions on tri-registration and how to do this step by step so that we can actually see how to apply this in clinical practice, and that will be Hani and I tomorrow. Now, of course, the other T is treatment, right? You have to, once you've planned all this, you need to place your stents, and then you move to the post-PCI workflow. In the post-PCI workflow, you'll have an IFR spot measurement, which will allow you to get a pullback. After you've done this and performed your post-PCI IFR pullback with co-registration, we're going to repeat the process and obtain another angiogram. And when we do that, we're going to end up determining exactly where the ischemia is. In defined PCI, that missed ischemia in 25% of patients, interestingly, it was spread out equally. 1/3 was distal to the stent, 1/3 was within the stent, and 1/3 was proximal in the stent. And what that co-registration allows you to do is simply determine, should your next step be placement of another stent, proximally or distally, or do you need to perform post-dilation inside the vessel? So we should always consider IVUS if the target IFR value is not achieved, there's pressure loss within the vessel, or there's a new pressure gradient that appears. Of course, the last step of the ACT PCI program is to improve, and that is consider high-pressure NC post-dilation for any residual pressure gradients in the stent, and additional PCI or IVUS for residual pressure gradients outside of the stent. And that split, again, is 1/3 proximal, 1/3 distal, and 1/3 within. And this is the full potential of what imaging and physiology can achieve together. Now, you all know that the defined GPS study has been performed. This is a very large randomized controlled trial. I was fortunate to be on the steering committee. 2,000 plus patients randomized to an IFR co-registration guided strategy versus standard of care, and currently that follow-up is ongoing. This enrollment has been completed and hopefully will be presented to you in 2028. Here's an example quickly of a patient with a baseline angiogram which shows a proximal vessel lesion. And so what we can do is determine that this is our potential target zone by angiography, and a second target zone distally, that's another area where we could end up putting in overlapping stents. But when we do our pressure pullback, all we do on our spot IFR is see that this value is 0.53, meaning this patient is ischemic. But remember, in the ACT PCI workflow, what we're going to do next is do an IFR pullback, so assess, and then we're going to co-register. And so you may have one of these patterns, but you won't know, right? That's the point of the co-registration. Is this diffuse disease? Is this multifocal disease? Or is this focal disease proximally with distal diffuse disease? And actually, when we did the Sync Vision co-registration, this is the pattern, which shows that you have multiple areas of focality and that the vast majority of these are step-ups. And so knowing this information, we plan to perform 2 stents, a 34 millimeter stent distally and a 38 millimeter stent proximally, which would bring the IFR estimate up to 1.01. And so you can see not only do you have an angiographically satisfying result, but also you've completely resolved the ischemia. One of the fundamental premise about defined GPS is that you may need longer stents to truly recover all of the ischemic territories, and hence, even in the setting of diffuse disease, potentially improve patient outcomes. And in this situation, we ended up with an IFR of 0.96. And then this is your post-PCI IFR pullback. Remember the ACT-PCI algorithm. Make sure that we don't miss any residual ischemia. There's some possible artifact distally, but you'll notice in the post-PCI pullback, there's no area with more than 1 dot together. So if you ended up with more than 1 dot, we'd consider that to be focal. Thank you very much.